Hello, greetings everyone. My name is Deontay. I am a family nurse practitioner and registered nurse practicing in Southern California. And today I will be your host for our presentation brought to you by my ALFtraining.com. And as you can see, our presentation topic for today is first aid. We'll be discussing some basic emergency preparedness, be giving you some information on emergencies that you may encounter, how you should react to those to keep not only yourself safe, but most importantly, the patient safe. So without much further ado, let's begin. So first, if you've been with me for a presentation, you know I like to begin these presentations with explaining to you why this topic is important. Because if you don't know why we are learning this, why this information is important and relevant, then how can I expect you to pay attention and really grasp this material? So, most importantly, I want you to know that caregiver training for the elderly and being knowledgeable about how to apply the information about first aid or responding to emergencies is regulated by the Department of Health. So it's a mandatory regulation. Now, each and every state, depending on where you practice, those regulations and mandates may be different. But one thing that does not change from state to state is the information being provided about those emergencies and how to care for the patient. And as you may or may not already know, caring for the elderly takes a lot of patience. It takes a lot of care, empathy, and skill. But the more skills that you have, the more qualified and self assured you will become to care for the patients. And these patients depend on us because they are no longer, for whatever reason, able to provide for themselves the daily care that they need. Maybe they need a little assistance, maybe they need a lot of assistance, but the bottom line is that now they depend on us. And so this skills and challenges and training that you're going to be going through to learn how to better care for your patients, especially during the emergency situations when they need us most, is going to be vital to your career and to their health. So, today's course objectives for what we will be discussing, you will first be able to list and identify the contents of a standard first aid bag. So there are some specific contents that are standard in the first aid bag as recommended by the American Red Cross. Second, you will be able to discuss and demonstrate appropriate actions in the event of a fire. You will be able to discuss and apply appropriate first aid treatment of minor cuts and scrapes for our patients. They fall sometimes, cuts and scrapes doing daily activities. So we need to know how to treat those. Next, you will be able to discuss and apply appropriate first aid treatment of bruises. That is important with bumps and bruises with our patients. Next, by the end of this presentation, you will be able to discuss and apply appropriate first aid treatment of minor burns and scalds. And last but certainly not least, at the end of this presentation, you will be able to discuss and demonstrate appropriate actions when someone is choking. And that is particularly important and scary situations if you happen to find yourself in it. Now, first, we're going to talk about what's in the box. What is in a standard first aid box? So I'm going to close our presentation just to open up this link here that's going to bring us to everything we can find inside of a standard first aid box, okay? So you should be mindful first and foremost of where the first aid boxes are located inside of the facility where you work. Which one is closest to the common areas which would be the living areas, the bedrooms, and the eating area or dining area. And also, if there are outside activities, you want to know where the nearest first aid box is to the common area where those outside activities are held. Excuse me. So, for a family of 4, this is what the Red Cross recommends, but we can also assume that these contents would be most appropriate if we're caring for a group of patients inside of an assisted living facility. So, first, 2 absorbent compresses, dressings. So, this is just going to be a type of gauze, but specifically, this gauze is a little more absorbent. 25 adhesive bandages, assorted sizes. So that's just a box of Band-Aids. 1 adhesive cloth tape. So that's some tape that's adhesive in case we need to tape gauze down, tape something down, what have you. 5 antibiotic ointment packets. So we need some packets of antibiotic ointment. And we also need antiseptic wipes. 2 packets of aspirin, 81 milligrams each. Now, 81 milligrams is a specific dose that's given as a preventative measure for patients when they are having a stroke or a heart attack. It's just used to begin thinning the blood. So it's used as a blood thinner for some elderly patients. This may be a medication that they're already taking on a daily basis. 1 emergency blanket, 1 breathing barrier with a one-way valve, 1 instant cold compress, 2 pairs of latex gloves, preferably size large, because that way people with small hands can fit them and people with large hands can fit them. 2 hydrocortisone ointment packets. Now, hydrocortisone is a steroid cream that is used, has many different uses. 1 3-inch gauze of rolled bandage, 1 rolled bandage, 5.3 inches of sterile gauze pads. We have more sterile gauze pads in a different size, a thermometer, 2 bandages in triangular shape, a pair of tweezers, and an emergency first aid guide. So that's a lot of things that's going to be inside of that box. Now, those contents should be inside of that box. We should note that most boxes in facilities have a checklist of the contents. So if you do use the contents inside of a first aid box, please mark off what you use to make sure that those supplies can be replenished. And there should be regular checks to make sure that our first aid kits or boxes are stocked. We don't want to realize that we're running low on supplies during an emergency. So make sure that at your facility, those checks are being performed. Now, first, we're going to talk about fires. And fires among the emergency events would be floods, earthquakes. Fires are going to be the most common, whether it's a problem with the electrical socket, microwave, those types of things can all cause fires. And those instances specifically are common causes of fires in assisted living facilities or residential facilities of different acuities or types. So, what are the fire prevention functions every person should know? And I have them listed here. These are the fire prevention functions that you should know. You should know the individual staff assignment in the fire plan. So there should be a plan of staff assignment of who's responsible for what in the event of a fire. Or there should be a list that you should know where it is. So if there is a fire, someone can begin delegating tasks to the staff to make sure that everything that needs to be done is getting done, and it's getting done by one person, and there's some type of order to the process. Next, location of the nearest fire alarm box and how to operate it. So we need to know not only where our first aid boxes are, but we need to know where the nearest fire alarm box is. In case there's a fire, it grows out of control. We need to know where that firebox is. Also, exits. This is pretty common. You should know where the exits are, but you should know to not prop them open or block access to these exits. Leave them as they are in the event of a fire. You should know or have some idea of where the gas mains are. And again, that individual staff assignment list that we talked about first, because someone should be responsible for shutting that off if the fire is beginning to spread. Also, you should know how to properly use a fire extinguisher. You should have general physical knowledge of the layout of the building. You should know that stairwell fire doors are to be kept closed. Why? Because you don't want the fire to be spread. Even if the door is very heavy or maybe you're trying to direct the residents out a specific door, don't leave the door open. It's only going to allow more oxygen to flow into wherever the fire is, and oxygen fuels the fire. And last but not least, again, touching on knowing the location of things, you should have an idea of where the main electrical switch panel or circuit breaker is and who has the keys to that room. So if there is a fire, we can call that person and they can turn off that circuit breaker. Next, general instructions in case of a fire. There are two acronyms you need to know. We're going to talk about one of those acronyms today, which is RACE, R-A-C-E. The second acronym that we would talk about would be SWEEP or PASS, and that's to educate you about the use of a fire extinguisher. But today we're going to talk about RACE and specifically how to use RACE in the event of a fire. So the R in RACE stands for rescue, the A stands for activate, C stands for contain, and E stands for extinguish and or evacuate. So R in RACE means that we want to remove the residents from the danger. The danger is the fire. Most important thing to remember during a fire is to not panic, because panic is the greatest danger that's there when there's a fire. Not the smoke, not the fire itself, but panicking. If panic is present, then that means the fire is no longer the danger. You are the danger because you're causing everyone to panic. So it's important to stay calm, not only for yourself, but most importantly for the residents, because if you're calm, then they're going to be calm and they're going to be more likely to follow your instructions clearly and quickly. You want to make sure that you don't shout, that you don't use excessive excited motions. Just be mindful of your voice, your volume, and your movements. The second letter in the acronym RACE is activate. Now, the A in RACE stands for activate, and that simply means that we want to activate the alarm. So we talked about knowing where the location of the fire alarm box is. You want to know where it is. You want to activate it. So you let other staff members know who may not be aware that there is a fire. And you want to also let the residents know that, hey, the fire alarm is going off. I need to find a staff member so that they can help escort me to safety. Okay, we want to let everyone know what's going on as quickly as possible. Next, we want to contain or confine the fire, and that's what the C in RACE stands for. And how can we confine the fire? We want to check the doors and windows to make sure that they're closed, okay? We don't want people trying to jump out the windows or running through every door. We want to keep the amount of oxygen flowing into the building to a minimum because this fuels the fire. Oxygen fuels the fire, okay? And last but not least, the E in RACE stands for extinguish or evacuate. If it is a very small fire and you feel comfortable that you can extinguish it and you have the means to do so, then do it. If you don't, then you want to use the RACE. So you want to let everyone know that there's a fire, contain the fire, and remove the residents. Emergency responders will extinguish the fire and evacuate for you. And sometimes they may tell you not to try and fight the fire. But if there is a fire extinguisher and the fire isn't out of control in your opinion, I can't give you the details as to what says a fire is out of control or what doesn't. If you think you can extinguish it, then try. If you can't, then close the door to where the fire is and evacuate. Okay, next. So when we talked about the contents of the first aid box, you may have noticed that I mentioned the word gauze a lot. And why would I mention the word gauze a lot, or when would we use gauze? And why would there need to be so many in a first aid box? And one of the main reasons that there are a lot of gauze in the first aid box is because first aid, we're going to be treating a lot of cuts. We're going to be treating scrapes. Okay. And elderly patients in particular are very susceptible to cuts or scratches. They may bump into things. Their vision isn't as good. Their mobility is impaired. They're stumbling sometimes, they're bumping into things. So they may scratch themselves. Now, you and I may also scratch ourselves sometimes, but the elderly patients in particular are at an increased risk for scratches and cuts because of their skin, because it's susceptible to aging. So it's become less elastic, it's become a little weaker, more brittle. And especially patients who are diabetic, they'll take twice as long to heal from a scratch. And even patients who are on blood thinners, which are a lot of the elderly patients, because such a significant portion of the population has had a stroke or has had some type of atherosclerosis that's leading them to be at risk for a stroke, or they've had a heart attack, so their doctor wants them to take blood thinners to keep their blood thin so they don't have a stroke or they don't have a heart attack. Now, the good thing is that they're taking this medication regularly to prevent such an event, such as a stroke or a heart attack. But the downside of that is that if they have a cut or a scrape, it's going to increase their bleeding significantly. So just a small scratch, they're going to bleed significantly. So we need to be prepared for this. We need to be ready. Okay. Now, as you can see here, this diagram can show you a superficial cut would be here. Now this full diagram shows you a deep cut. This looks like it was some type of a puncture. So maybe this patient was helping wash the dishes and they cut themselves with a knife or they squeezed the knife. I'm not sure, but this is a very deep cut because it extends to the muscle, through the fat, through the skin. Okay. Now, if it just ended here and above, this would be more superficial. But either way, I want to talk to you about how to apply first aid to a patient who has suffered from a cut or a scrape. When treating a cut or a scrape, the first thing you want to do is place a sterile bandage on the wound and apply firm pressure for 5 minutes. Now, this pressure that you're applying has to be uninterrupted. You're going to be very tempted to look and see, has the bleeding stopped? Is the patient bleeding? Can I let go of their arm now? Maybe they're telling you that they're fine, and maybe you're putting very firm pressure, which is good, but it's hurting the patient, it's making them uncomfortable. Okay. Don't look. 5 minutes. Okay. Then you can remove the bandage. You can see if the bleeding has stopped. You can assess the wound. And you'll see in this diagram here, it looks like this patient cut their forearm. It looks like they're in a seated position. And you'll see that the medical professional has their hand and the cut raised up in the air, okay? And then this means that he or she has raised the patient's arm above their heart. So that means blood isn't pumping through the wound. So this is also going to help the patient and the medical professional by slowing the bleeding and slowing the blood flow. So if the patient has cut one of their upper extremities, then you want to raise that arm or hand above the patient's head, hold their arm, and apply firm pressure. Oh, one more thing to add. So if you're holding pressure on the patient and it's been 5 minutes, let's say it's been 3 of the 5 minutes, and you notice that the gauze that you're holding on the patient's wound is saturated with blood. Get another gauze, put it on top of the one that you have without breaking the constant pressure that you're holding and apply more pressure with that gauze, okay? Don't take that gauze off, that soap, put it down, and then get a fresh gauze because then you stop that constant pressure for 5 minutes and you're going to have to start all over again, okay? So 5 minutes uninterrupted pressure. Next, let's say our patient has bumped into the door and they didn't cut themselves, but they did get a big bruise on their arm, okay? And maybe they didn't even bump into the door that hard. Again, elderly patients, they don't need to bump into things very hard to injure themselves significantly because their body is going through the aging process. And with that aging process, the skin loses its elasticity and it's also losing some fatty layer that helps provide cushion against harm, like you and I. Now, additionally, medications such as blood thinners, as we talked about, or other medications that make the patient at an increased risk to fall also contribute to frequent bruising among the elderly. So, what do you do if you notice that your patient just bumped into something or fell or hit their knee on the table and it's red, but it's not bruised yet, but the patient's in some pain? What do we do? Well, when that injury to the body happens, and you suspect that the patient may have a bruise, the first thing you want to do is you want to apply a cold compress to the area, okay? And when I say cold compress, I don't mean an ice pack, maybe an instant ice pack, but not ice cubes that you make a pack. And I'll explain to you why not in a minute. So preferably you want to use a cold compress on the area, wrap a towel over the skin and the cold compress to secure it in place, not too tight, just tight enough to keep it in place. And this will help reduce swelling and blood flow to the area. And it should help ease the pain a little bit. And now you don't want to use ice cubes because it takes ice cubes a very long time to melt. And that increase in cold may cause the patient some uncomfort, and they may be less likely to keep that ice in place for it to work. Or they may leave it in place for too long because maybe this patient has a decreased sensation to that area. Maybe they have some type of neurological disorder where they have decreased feeling to that area, or nerve damage. So they can't tell you that that ice pack is too cold. And then it will just cause them, and we don't want to have that on the patient that's too cold, no extreme temperatures, okay? So let's keep it to a cool towel. We'll change it out as needed and we'll watch for bruising to that area, okay? Now, next, this is very common amongst patients in the assisted living facility. Why? Because they all love a good cup of hot coffee or hot tea. But mistakes happen, accidents happen, and a minor burn happens very frequently. Okay? So we need to be prepared for this. We need to know what to do and we need to know how to do it. Now, a minor burn, this is something that we can address. And the main things that will help you distinguish between a minor burn and a major burn, something that we need to call 911 for, is a minor burn or superficial burn. You'll see some redness just on the top layer of the skin, okay? It'll look similar to a sunburn. It will be painful for the patient. There may be blisters on an area, but this area should not be larger than 3 inches in diameter. Okay. If it's larger than 3 inches in diameter, then that may classify it as a major burn. Okay. So it'll be small, red, painful with blisters. So we know what to look out for. Now we need to know what to do. So in the event that your patient spilled some coffee on themselves, or maybe they turned the water in the faucet on, put their hand under the water, and it was really hot and it burned them, or they were helping out with the tea kettle and some of the water splashed on their leg, okay, or their foot. First things first, we want to cool the burn. Excuse me. So first things first, we want to cool the burn. And how do we cool a burn area? With cool water, right? Not cold water, but a cool water temperature. And we don't want to run cold water on the area. We want to apply a constant cool pressure. So we're going to use a cool towel again, okay? We don't want to put the skin from one extreme temperature, which would be the heat, the excessive heat that caused the burn, and then put it under another excessive temperature. Well, it'll be excessive cold water because the skin's not going to like that drastic hot cold, okay? So we're going to use a cool wet compress until the pain from that burn eases a little bit, okay? Until the patient settles down. Then we're going to remove any rings or tight items from that area because sometimes what happens when the skin is burned, it starts to swell and it brings in water from the cells to try and treat the injury. So we might notice some swelling. So you want to take any rings off and let the patient know why you're taking their rings off or their bracelet or whatever jewelry or whatever it is around their wrist or their finger, okay? And don't break the blisters, and make sure you tell the patient not to break the blisters. Even if it's big and it looks like it's painful, don't break it because you're only going to make the patient more susceptible to getting an infection because that area will be an open sore now, okay? And if they do have a blister and it breaks, you clean the area every day with soap, which is optional, but preferably you just want to scrub the area gently with water and make sure you use the antibiotic ointment. Now, the doctor may prescribe one if you've let them know. Otherwise, there will be an antibiotic ointment and should be an antibiotic ointment in your first aid kit. But if the patient develops a rash, which is unlikely, but it can happen, stop using the ointment, let the doctor know, let the nurse know, okay? And we can get something to treat the rash. Now, the next step, apply lotion. Now, this is recommended by in some journals by my research, and some journals, they don't recommend it, but they don't recommend against it, if you understand. So applying lotion, if you can imagine, once a burn is completely cooled, then you can apply lotion. So the skin isn't burning or painful anymore. We've cooled it down with a cool towel, okay? Now you can use some type of moisturizer because the skin is dried out. The same way when you have a sunburn, the next day it's flaking, it's peeling, it's because it's dried out. So after a patient has a burn, it's okay to apply lotion that has some type of aloe vera or moisturizer. And this can help provide some additional relief for the patient. And it can also aid them in the healing process because the skin has a little bit of moisturizer to keep it from becoming dry and cracking, okay? And last but not least, we need to bandage the burn. And this is going to make sure that if the patient hits it or goes outside or washes it, that it's not susceptible to all these changes in temperature and it's not susceptible to being hit or anything, okay? So bandage the burn. And again, you see sterile gauze, not the fluffy cotton gauze, but it's going to be a knitted, clean, skinny gauze, okay? It's not going to be thick and fluffy. You'll notice the difference, and the packaging should be labeled sterile gauze inside of your first aid kit. Okay, last but certainly not least, one of the most important topics we'll cover today is going to be choking. As you can imagine why choking, this section is very important in our discussion about first aid and emergency preparedness. Now, the universal sign that someone is choking, no matter what language they speak, no matter what age they are, is they're going to put their hands around the throat like this, okay? And if the person doesn't make this signal at you, but you may suspect that they're choking or someone tells you that they're choking, the way you want to assess the situation is by checking for these signs here. So are they able to talk? So you say, sir, ma'am, are you choking? Then you want to assess for difficulty breathing or noisy breathing. Okay, so you can just listen to see if air is coming out, or you can watch their chest for chest rise and fall. Now, this may be difficult because if someone is choking, they're going to be panicking. Okay. Next, you want to look for a cough. So you say, sir, ma'am, are you choking? And they don't have a response. Can you cough for me, please? If you're choking or not choking, can you cough? You want to assess when they cough how weak or strong the cough is. And this is going to let you know whether they will be able to assist you in eliminating whatever is stuck in their airway, or whether you're going to be doing a majority of the assisting in this situation to alleviate whatever it is that's blocking their airway. Another key sign is going to be to assess their skin, their lips, and their nails. Okay, if they're looking down or they're flailing around, you want to check their skin, their lips, grab their hand, look at their nails. If they're turning blue or dusky, maybe if it's a Caucasian patient or a patient with lighter skin, then their skin may be turning red. If it's turning red or blue or pale, you want to note those different colors, okay? And last but not least, a loss of consciousness. Is the patient's eyes open? Are they looking at you? Are they looking around? What's going on? You're assessing the patient to see what the situation is, okay? Now, next, if the person is able to cough forcefully, remember that was one of the things I talked about just on the previous slide, was is the patient able to cough and how strong is the cough? So if the patient is able to cough forcefully, so if they have a good amount of strength behind the cough, and you'll know when you're in the situation, then the person should keep coughing. So you should encourage them to keep coughing. But if the person is choking and they can't talk, they can't cry or laugh forcefully, or just imagine if they can't talk, or they're not crying or able to scream or make any noises, then the American Red Cross recommends a 5 and 5 approach to delivering first aid. Now, the 5 and 5 approach refers to 5 back blows and 5 chest thrusts, okay? Now, chest thrust is another word for the Hamlet Maneuver. So the American Red Cross recommends 5 back blows and 5 chest thrusts, switching between each. So 5 and 5 and 5, until the patient either becomes unconscious and needs basic life support, so CPR, or until the particle or food or whatever it is that's in the patient air that is lodged inside the patient's airway becomes dislodged and they're able to breathe again. Now, the American Red Cross recommends back blows. So we'll talk about the procedure for applying back blows right now. And remember, you're administering back blows at a maximum strength. And how do we do that? Well, you stand to the side of the patient. You place one arm across their chest. So one arm across the chest like this for support, because you're going to be hitting them at maximum strength. And you also want to bend the person over at the waist. This is going to help. This is going to bring gravity on your side a little bit. And also it'll make it easier for the patient to cough up and whatever item to fall out of their mouth, their airway. So you're going to put one arm around the patient, bend them over at the waist so that their upper body is parallel to the ground. So they should be looking at the ground, and you're going to hold them up, and you're going to deliver 5 separate back blows between their shoulder blades, so right in the middle of their shoulder blades, with the heel of your hand. So the heel of your hand is going to be the part right above the wrist, okay? And that is recommended by the American Red Cross. So they recommend doing 5 back blows alternated with 5 chest thrusts. Now, the American Heart Association, which verifies or provides certification for BLS and CPR, they recommend the Hamlet Maneuver. So we'll talk about the Hamlet Maneuver, also known as chest thrust. Chest thrusts are recommended to be done at least 6 to 10. So how do we administer the Hamlet Maneuver? You've probably seen this done in the movies or on TV, so you have an idea. But we're going to talk into specifically on how it's done in 3 easy steps, okay? First, you want to stand behind the person who's choking. Place one foot slightly in front of the other for balance. So you're going to have one of your feet slightly in front of the other to give you some balance. You don't want your feet to be directly across. You want one in front of the other. You're going to wrap your arms around the person's waist and tip the person forward slightly. Make a fist with one hand, preferably your dominant hand, and position it slightly above the person's navel or below their rib cage. So somewhere between the navel and their rib cage, the bottom of their ribs. And then you're going to grab your dominant hand, which should be in a fist, with your non-dominant hand. You're going to grab your fist, and then you're going to pull hard into the abdomen with a quick upward thrust. So you're going to pull up like you're trying to pick the person up. And you're going to do all that in one strong sweeping motion, and that's considered one thrust, okay? You want to make sure each one is separate and strong. So 1, 2, 3, until you get to 6, okay? Now remember, you can alternate your chest thrusts and back blows, and that's recommended by the American Red Cross, or you can simply begin with the Hamlet Maneuver, which is the chest thrust, which is recommended by the American Heart. If you want to talk to someone in your facility about which one they prefer, then please do so. I encourage you. But these are the simple steps to apply each of the 2. Now, I want you to watch a short video because choking is very serious and can quickly escalate to a life-threatening emergency. So I want you to see visually how back thrust and chest thrusts are delivered, but specifically because of the population that we're caring for, the elderly population, I want you to see how to perform first aid on a patient who is choking that's in a wheelchair. So this way, if the patient is in a wheelchair and they're sitting at the kitchen or they're sitting in the activity room eating a snack, we know what to do in the event that they're in a wheelchair, because I have personally witnessed a patient choking in a wheelchair. And of course, if a patient is in a wheelchair, it implies that they need a bit more of assistance. And in my opinion, they are more likely to choke, because patients who are in a wheelchair more commonly have suffered from a stroke. And patients who have suffered from a stroke, a lot of the times have trouble with swallowing appropriately or safely. So we're going to watch this video and I'm going to talk you through it.
The most important thing with any victim is that the airway is the priority. The wheelchair can often be a distraction from the main focus, which must remain the removal of the obstruction fast.
What's up? Neil, look at me. Can you cough?
In the first instance.
So see, the first thing he asks the patient is, can you cough? So he's assessing if the patient can cough, and if the patient can cough how forceful or how strong the cough is.
Encourage the casualty to cough. If they are unable to cough,
Can you cough?
or it is clearly not working,
Can someone help me, please?
shout for help and apply the brakes.
This is a big thing to remember, because when the patient is in the wheelchair, or even if they're not in the wheelchair, when someone is choking, it's a very quick emergency, and we want to respond quickly. And more importantly, we want to respond appropriately the first time. So you want to apply the brakes, because if you don't apply the brakes, every second we waste trying to administer back blows or chest thrusts, the wheelchair is rolling around, it's not going to be effective and it's not going to be appropriate. So first thing, take it from someone who has seen it done wrong, we want to apply the brakes.
Lean the casualty forward and administer a maximum
1,
of 5 back slaps
2,
between their
3,
shoulder blades.
4,
If
5.
this doesn't work,
So notice how he placed one arm in front of the patient, holding him up, and he administered 5 separate back blows. Now, of course, this isn't a real choking situation. This is a reenactment, but your back slaps should be a lot firmer and harder, okay? We're trying to dislodge something that is in the patient's airway. This is an emergency.
if this doesn't work, place your arms around the casualty. Grasp your hands together, forming a fist, and pull.
Now see his right hand, he made a
Inward.
fist, and he put his left hand on top, right below. You can imagine he's right in the sweet spot. So below the patient's rib cage and above the patient's navel, okay?
And upwards, sharply beneath the rib cage. Do this for a maximum of 5 attempts. Remember that if at any stage you think you have dislodged the obstruction, check the casualty's mouth and remove it if possible.
So she said, if you think that you have dislodged it, maybe you heard them cough, but they're still slumped over or not responding, not responding, but they're still slumped over. They still appear like they're in distress, but you think that you may have dislodged it. You want to stop, check their mouth. Maybe the food particle is in their mouth. You don't want to keep doing the Hamlet Maneuver and they have the food that they were choking on in their mouth, and then they swallow it again, okay? But more than likely, if you dislodge whatever it was that was blocking their airway, the patient is going to tell you, or you're going to know for sure.
Oh, can you get an ambulance, please? Got a full obstruction here. Yeah, no problem. Okay, no worries.
So notice how he's alerted someone that there is an obstruction in the airway. He did 5 chest slaps. He did about 6 to 10 thrusts, chest thrusts, and now he's doing back slaps again, okay? So we're noticing that whatever is lodged in the patient's airway, at this point, we may or may not be able to get it. And every second that goes by is this patient not getting oxygen. So this is an emergency. We may need the assistance of 911, of the ambulance. So we need to call help immediately. But he does not stop.
Ambulance, please.
He keeps
Yeah, hi, we've got a guy who's
first
choking
aid
in his wheelchair and we can't remove the obstruction. We've tried everything we possibly can, but we're very, very concerned now. I wonder if you can come out to us as soon as possible, please.
If you have somebody with you, send them to call an ambulance as soon as possible, while you continue to attempt to remove the obstruction. If you are on your own, repeat the cycle of 5 back slaps, followed by 5 abdominal thrusts 3 times. If you have not been successful, leave the casualty, call the ambulance, return as quickly as possible, and continue with a cycle of 5 back slaps.
So that is if you are by yourself with the patient who is choking and no one else is around. You do 5 back slaps and 5 abdominal thrusts 3 times. So you do a total of 15 back slaps and 15 abdominal thrusts, but you alternate 5, 5, 5, 5, 5, 5. And then after you've done 5, 5 3 times, you leave the patient, you call the ambulance or let someone know to call the ambulance, and then you return quickly to the victim or to the patient.
And 5 abdominal thrusts. The following techniques can be used in situations where you cannot do conventional abdominal thrusts. The first technique is modified abdominal thrusts from the front. Secure the wheelchair by backing it against a wall or
So these are alternative techniques if you cannot perform a standard abdominal thrust on a patient, perhaps because this patient is too large and your arms can't wrap around them. You can't get a hold of, you can't grab your fist with your non-dominant hand, okay? Then what do? You need to be able to provide some type of abdominal thrust, and this is an alternative technique to do so.
steady furniture and apply the
So what you're going to do is you're going to push their wheelchair up against the wall or up against some type of furniture to provide resistance against your forward abdominal thrust, okay? And then you're going to, of course, lock the brakes on the wheelchair.
brakes. Deliver the modified abdominal thrust using the technique shown here, alternating with back slaps. An example of when you might consider this technique could be when your arms cannot reach around the casualty to deliver abdominal thrusts in the conventional manner. The next technique is chest thrusts. These are administered by standing behind the casualty and pulling sharply inwards in the center of their chest.
Now, again, this is if you can't put your arms around the patient's stomach, above the navel, right below the rib cage, because they're too large. Then hopefully you can wrap your arms around their shoulders and do chest thrusts, okay? But remember, first priority and most effective is the Hamlet Maneuver, delivered with wrapping our arms around the patients in the midsection area, right above the navel, and also performing back slaps. So the chest thrust will be a substitute only when you cannot do the first option.
Chest. Once again, alternate these with back slaps. If you are unsuccessful in removing the obstruction, you must consider getting the casualty out of the chair and onto the floor.
Now, this is if you are unable to remove the obstruction from the patient, they're turning blue, then you need to get the patient out of the wheelchair onto the floor. Why? Because you need to begin CPR. Okay, so that is our presentation for today. Ending it on a serious note, but nonetheless, the information presented is very important, life-saving information, and I hope that you were able to take something from today's presentation. And I'm going to quiz you right now. We have a 2-question quiz. Some basic knowledge I'll be testing to see how well you understood today's presentation. Okay, so our first question. While doing rounds, you note a patient bump into the doorway and cut their arm. They call out for assistance and you respond, noting there is blood coming from a cut on their arm. You reach into the first aid kit and pull out which item first. So if you note a patient cut their arm, they call you for help, you're the first to respond. You grab the first aid kit off the wall because you know exactly where it is. What is the first item you're going to pull out? Is it going to be A, sterile gauze, B, a large Band-Aid, C, an ACE bandage, or D, antibiotic ointment? What is the first item you're going to pull out? What do? The patient's arm is cut. they're bleeding, they're crying for you, they need your help. What's the first item you're grabbing out of the first aid kit? If you said A, sterile gauze, you are correct. The first thing we want to do is stop the bleeding, okay? First, we want to stop the bleeding. We can't assess the wound and apply antibiotic ointment because it's bleeding. It's bleeding everywhere. As soon as you wipe the blood away, the blood comes back. We can't apply antibiotic ointment. The blood's going to wash the ointment away. It's not going to be effective right now. Our number one priority is stopping the bleeding, and we can do so with the clean, sterile gauze. If it was their arm, I showed you the image on our slide about cuts and scrapes. Preferably, preferably you can get the patient somewhere where they can sit. You can raise their arm above the level of their heart and hold pressure for how many minutes? 5 minutes. And remember, no peeking, because if you look to see if the bleeding has stopped and it has not stopped, then you have to start again and hold pressure for another 5 minutes, okay? And if the patient says, ow, you're hurting me, that means you're holding good pressure, okay? So, question number 2. Question number 2 is a short question, a short and simple question. I know you know the answer to this one. The greatest danger in most fires is the presence of what? Is it A, smoke inhalation, B, electrical outlets, C, unfilled fire extinguisher? So the fire extinguisher is in the box. It looks like it's ready to go. You grab it and there's nothing in it. It's not filled, okay? We didn't have those forms being checked on the unit or in the facility to make sure that our fire extinguishers are filled and ready to go. Or is it D, panic? What is the greatest danger in most fires? Give you a second to answer this question. Okay, the greatest danger in most fires is the presence of panic. Remember, it is important not to panic, because if you panic, that is going to cause your patients to panic. The residents are going to panic. People are going to forget things. They're not going to be able to follow instructions clearly because they're going to be too nervous, because a fire is very scary. It's very real. But in this event, we know what to do. We know to close the windows, to close the doors, to have an evacuation area, to contain the fire, right? We remember RACE, R-A-C-E, RACE. That is our fire general instructions. RACE. Remove the residents, activate the alarm, contain the fire, and extinguish the fire if we can, or evacuate. Simple as that, RACE. So we know what to do if there's a fire. We know what to do if there's a cut. We know what to do if the patient is choking. You should have a good grasp on first aid delivery for elderly patients living in an assisted living facility, a residential facility, an assisted care facility, what have you, right? Thank you for being a part of today's presentation, for being here with me for the past hour. My ALFtraining.com thanks you. We welcome you to join us again for another presentation on a different day at a different time. But my name is Deontay, and it was my pleasure presenting to you today. Again, I'm a family nurse practitioner in Southern California, and I hope to see you again soon. Thank you, and have a good day.